I am Dr. Kawita Bapat. Today we are very happy to have our own person, Dr. Neerja Pauranik. She is an obstetrician and leading gynecologist and lactational consultant from Indore, and she was former HOD in Bombay Hospital, Indore. She served as the Secretary President of Indore OBGYN and President of Indian Menopause Society, Indore Branch Treasurer, Empower also. She is a city coordinator, assessor, and a life member for the Breastfeeding Promotion Network of India and member of Executive Committee, Madhya Pradesh State Level Monitoring Cell for the PCPNDT Act. She is a recipient of Parshuram Award, Nari Shakti Award, Kamal Shakti Samman, Wonder of Foxy Award, first award-winning video in Foxy National Competition for Breastfeeding Promotion, Best Paper presented in BreastCon, and Nanik Bhaskar Women Achievers Award, Breast and Puerperal Health Committee, and Foxy, and so more. I'm so proud about my own friend, Dr. Neerja Pauranik. Her dedication regarding breastfeeding is ultimate, and she is very hardworking in this manner of doing breastfeeding. She likes to promote about breastfeeding. She herself follow all the rules, and she is the, I think, number one hardcore supporter for the breastfeeding. So thank you so much, Nirja, for being with us in a grand rounds, and I am so happy.
Thank you, Kavita, for kind introduction. And first, at the outset, I must thank Kavita, madam, for giving me this great opportunity to speak from this important platform, and that too on a very important topic which is so close to my heart. And the topic chosen today is optimizing support for breastfeeding as a part of obstetric practice. I think I will be doing justice for this topic. So the scope of my subject will be role of antenatal sensitization. Secondly, I will be covering technical minutities of the golden hour as an obstetrician, then breastfeeding in the immediate postpartum period and why to insist on skin to skin, some clinical cases if my time allows and my own data, and lastly, a poem of 2 minutes only. Just imagine there is a new vaccine which has arrived in the market. It can prevent millions of infant deaths per year. It is almost free, can be orally administered. There is no need for maintaining the cold chain. It is very safe, no side effects. And apart from immunity and other benefits, it is available everywhere, every time at the right temperature. Such a vaccine should immediately become a public health hit. Yes, but unfortunately, this is not so. Breastfeeding is that wonder vaccine, and it is much, much more than that. And this vaccine needs a warm chain of support like this, which we are doing. And Dr. Kavita, madam, has allowed me to do it on this platform. And these are not my words. This was an editorial which was published long back in 1994. And still, even after today, after 30 years or more, the message still holds true. Breastfeeding is not a rocket science. Historically viewed, it is considered as a purely natural process requiring minimal medical intervention. But nowadays, we know that it's a clinical priority. It's not just a natural instinct. Our goal should move not merely from encouraging or actively optimizing support protocols, but we should be optimizing it actively. Current evidence shows that successful lactation reliance on systemic hospital support and early clinical guidance. The obstetrician is the primary point of contact, setting the foundation long before the delivery. Antenatal sensitization gives us the opportunity to build knowledge, confidence, skill for breastfeeding. Higher initiation rates are there. There is reduced early cessation and there's better maternal infant bonding. Antenatal preparation is not just an education, it's an empowerment. WHO describes no specific time. In fact, it says that conversation on breastfeeding should begin whenever possible, as early as in the first trimester, so that there is a time to discuss any challenges if necessary. If conducted earlier, women are likely to forget. If conducted in 8th or the 9th month, the pregnant women are unable to sit and listen for a longer time. And if she delivers prematurely, she will miss the opportunity. While the postnatal counseling is more often done, the antenatal counseling is neglected, though it has a more advantages. Like the pregnant women are very keen to get the information and has time. We can demonstrate the things. She can plan things in advance, and usually the postnatal counseling is done for the practical help and the problems which arise. The meaning of high risk pregnancy for obstetrician are well known. But here we are talking about the high risk pregnancy with reference to success of lactation. The antenatal breast examination can diagnose hypoplasia, tubular breast, previous breast surgery, and where is the location of the scar. But one should never comment on the flat or retracted nipple or small breast or a large breast, etc. This slide is very important and it should be projected in every clinic. And we should tell our family members that the requirement of the newborn in the first few weeks is very less, first week rather, and it gradually increases. And colostrum comes in drop by drop. And relatives must not expect a free flow right from day one, and the faulty perception that sufficient milk is not coming robs the newborn from magical gift of colostrum, making the baby a victim of vicious cycle. As you can see in this diagram is this slide, the size of the stomach on day one is only 5 to 7 ml, and we put so many 30 ml of formula feed into the stomach of the baby as soon as the baby is born. Then coming to the golden hour, and it should be the rule. As an obstetrician, I know how cumbersome and practically difficult it is to follow this golden rule. But in spite of all odds, all adverse comments, all the eyes staring at you, you have to do it and mind it. Slowly and gradually, it will become an easy and external factor will become milder and milder. Everyone will accept that, oh, Dr. Puranik is doing the delivery. Now you have to be here for 1 hour. So, identification of the particular staff who will be performing the duty of the golden hour is very, very important. Otherwise, at the 11th hour, you are not getting any staff for to do this. And it is like a checklist of all the gadgets we do it before starting any surgical procedure. Just check the baby has cried immediately with the good Apgar. I just need a green signal from my pediatrician. And there is no need of suction or oxygen. There is no need to take the weight or give the vitamin K immediately. And on the part of we, the obstetrician and the pediatrician, who often fail in giving much needed support for the immediate breastfeeding, there is some kind of inertia, doubt, and hesitation in us. Baby has to be put with the naked chest of the mother horizontally. Keep ready a small, not a big sheet of to cover back a newborn of the baby, because in the big sheet the newborn you can't hold the baby properly, and cover the head of the baby with the cap, or in OT you can use the sponge like this, which I am using the sponge to cover the baby, and switch off the AC. There is no need to clean the breast. Sometimes there is a reflex that we have to clean the breast. Don't force the nipple or the breast into the baby's mouth. And the baby will be quiet for 10 to 15 minutes, mind it. The baby is not going to move. Just do some activities, that's it. And observe the baby and see as such requires patience. Then I always take up the task because my task is over by the time between 10 to 15 or 20 minutes, and the baby starts sucking and the credit goes to me. If left quietly, the baby will crawl, and to observe the breast crawl is an amazing activity which one can see in the golden hour. The baby will crawl the breast because of the odor of the nipple, and odor of the nipple is going to guide the journey of the crawling. It's very interesting if the right breast is washed with soap and water, and the infant will crawl to the left breast. And if both the breasts are washed, and infant will move to the nipple that was painted with the amniotic fluid. This is such a beautiful physiology. Skin to skin contact releases massive amount of maternal oxytocin via afferent vagal nerve stimulation. And apart from reducing the postpartum hemorrhage, it is the primary driver of milk ejection reflex, that is MER. During birth, the neonate has high secretions of catecholamines because of the stress of the labor, which makes the baby very alert, and his sucking reflex is maximum. And this alert window is the golden hour which we should be utilizing. The sucking reflex will disappear after an hour, and newborn will enter into the deep recovery sleep. And latch will become difficult, and it will appear after 24 hours. The mammary gland have immense amount of prolactin receptors, and they are dynamic. The density is dynamic. The early stimulation of sucking and breast emptying in first 48 hours increases the prolactin receptors density, and if no stimulation, density will fall and lactation may fail. Placing the unclean baby on the maternal chest activates the enteromammary microbiome pathway, and it allows the immediate transfer of maternal commensal flora, and combined with the oligosaccharide in the colostrum, it initiates colonization of the neonatal gut microbiome. Then what is colostrum? Everyone knows. Rich in antibody, protects against infection and allergy. Its purgative action clears the meconium. Many white cells and growth factors helps to prevent jaundice and helps the intestine to mature. And it is rich in vitamin A, and it prevents the eye-related diseases. Newborn's intestinal mucosa is absolutely sterile at birth, but at the same time it is extremely permeable. So these few drops of colostrum will paint the gut mucosa by the colostral secretory IgA through surface tension, and gut mucosa is prevented from getting infected. Then coming to the pain management and pharmacokinetics. The ergonomics and analgesic supplementation are very important, because if she has undergone cesarean section, there is a pain. If vaginal delivery, episiotomy is pain is more horrible. And these mothers are battling with severe incisional pain and restriction of mobility. So it is the duty of obstetrician to teach alternative feeding positions like lat back, and the best, in my opinion, is side lying position. And never force the mother to sit and feed, which is very often, and I should say always, advised by nursing staff, pediatrician, obstetrician. Encourage her to feed in sideline position till 6 weeks, I should say, so that she can enjoy the feeding, and in between she can take a short nap also. Maternal pain inhibits oxytocin letdown reflex, and adequate postpartum analgesia is crucial for breastfeeding success. A mother writhing with the pain cannot physically or emotionally focus on establishing a deep latch. Discuss with your anesthetist to avoid drugs which may lead to neonatal central nervous system depression, hypotonia, and poor sucking. If the baby is in ICU, sometimes it happens, the mother is not able to feed, then the manual expression should be initiated within 3 hours of delivery to program the breast. This is the lying down position. The routine separation of in the operation theater should be condemned. Nursery culture has to be eradicated, and 24 by 7 rooming in is non-negotiable. It aligns maternal and infant circadian rhythm and allows mother to recognize early feeding cues. And just see the physiology, the ergonomics, like the axis of the baby is horizontal in both the condition, this and this, in sideline position. And it's a myth that it will lead to ear infection in the baby, and mother is lying comfortably on her back. So back is supported, baby is in close contact with her abdomen, and she need not to hold the baby and breast also. And I was very happy to see this painting endorsing breastfeeding in sideline position. And this is a painting by Japanese artist. It was seen in Kashi Sarnath temple. And look how this young Siddharth, before becoming a Buddha, is leaving his sleeping wife and the son Rahul, who is doing breastfeeding in lying down position. So This position avoids pain of posture change change of sitting, helpful in the night, maximum skin to skin contact, tummy to tummy touch, and as soon as the baby latches, pull the baby closer to the mother for the skin to skin contact, and a small cloth rolled up is tucked behind the nape of the baby. So in short, the skin to skin contact has both the mother and baby. In baby, it has advantages of thermoregulation, oxygenation, stabilizes heart rate. Baby listens to the heartbeat of the mother, and the cortisol level goes down and reduce crying, stabilizes the blood glucose, stimulates the self latching, and it stimulates the coordinated sucking also. And in mother, naturally it increases the oxytocin. The milk is coming in just adequate. The promotes bonding and heightens the confidence and so on. She is my patient mother delivered only 1.9 kg baby, and this baby used to sleep like this only. And at the age of 3 months, the baby is looking like this. So encourage father also to do skin to skin contact. And these are the obstacles. The feeding bra and feeding gowns are not recommended. So we in antenatal counseling only we can tell the mothers that not to buy these clothings. So the best solution for all the problems like difficulty in latching, low milk supply, breast refusal, induced lactation, relactation, the answer is skin to skin contact. And this was the slide made by me with great efforts. And this is our Abhimanyu, and the Abhimanyu is facing all these problems. So, if the time is not much, then I can skip over these my patients' stories or what?
You can continue
Yeah.
whatever the best for you.
Okay, okay. So the Richa has undergone C-section at 40 weeks. Baby cried immediately. Suction done, oxygen given, vitamin K as usual. The baby was cleaned and after clothing shown to the relatives, kept in observation for 24 hours as a routine hospital delivery. And the top feeding was given twice. A full-term healthy baby doesn't need anything except colostrum coming in drops and drops. A newborn has 20% extra calorie in store at birth, which is used as a buffer for mother and baby to figure the things out. This is Sheenam, delivered by C-section, and she had a bilirubin level as high as 18. Then the phototherapy was done, and on 20th day, again the bilirubin was found to be high. The previous she consulted four pediatricians, and generally four opinions have multiple confusions, but everyone asked her to stop the breastfeeding and said that it is a breast milk jaundice. But Cheenam continued breastfeeding, and um, uh, this should not be done. The artificially fed infants has relatively low levels of bilirubin. This is very strange, but it is a fact. That's why the pediatrician they advise to stop breastfeeding so that the bilirubin will fall down immediately. But that is not the plus point for formula by any means. We should counsel the mother that you should continue the breastfeeding. And this Sanchita delivered a full-term baby. As a routine hospital practice, blood sugar was done and it was found to be 36. So it was called as an emergency. Immediately 30 ml of top feed was given to cope up this so-called emergency. Then Winnie she's highly educated and very much motivated for breastfeeding, but she doubts her own supply when her baby suddenly start demanding feeds the whole night, and it was cluster feeding in growth spurts. The baby demands at an interval of even as early as 15 to 20 minutes, and relatives and mothers believe that the milk is not produced in sufficient amount. So the growth spurt should not be labeled as a low milk supply. You have to count the P's only. And my own daughter, Anvita, she is a pediatric neuroradiologist at Vancouver, and she is a hardcore breastfeeding supporter more than me. And she delivered by C-section. Only cheek to cheek contact was done. Kavya, my granddaughter, lost 11% of the weight. and generally it is 7 to 10%. And she was advised formula. Weight loss is observed in first few days, and the range is 7 to 10%, as I said. The variability, and it depends on the variability across the individuals and different races, and many sources of error can be there. The one machine may be other, the marking may be other. So regaining weight may sometimes be delayed, and excessive worries about the weight loss is another common cause of top up trap. And everyone will come to us that अरे मैडम एक ही बॉटल हम तो रात को देते हैं and that's it, just one bottle won't hurt. So even one supplement per 24 hour will result in shift from the breastfed formula to the fed gut flora pattern, and it will take recovery even 2 to 4 weeks for the intestinal environment to return to normal. So the bottle feeding, I sometimes label many a times as Putna Mosi, who has come to us to give problems to our babies, and this is real mother. So my data in my in 2.5 years, I have seen nearly 157 or some more mothers who came to me for breastfeeding problems. So the golden hour was followed only in 3.4%, and that too not for even 1 hour. The mode of delivery was naturally 67 in LSCS and vaginal 32%. And many more than 50% they complain of low milk supply, which was not a real thing. And as a vigilant obstetrician, we should discourage keeping the baby in cradle, and use of pacifier. Swaddling should be discouraged. In social media, you can see so many videos for how to swaddle the baby. This is not good. And this is पूरा पत्ता गोभी बना देते हैं. Overheating of the baby, and skin to skin touch is not there in these babies. And this is a small story of journey of bottle to breast in Indore Zoo. Indore-based NGO built a baby care room for mothers, and coming to Indore Zoo before the inauguration, they came to me, and then I suddenly noticed that on the front wall there is a big picture of mother holding the baby with a bottle. So I strongly objected. I contacted them. They said that that painter has gone now. The painter is not in the town now. So I hired a different painter, and immediately she this painter charged me 5,000, but I said, no, no, you charge, but just change this painting. And now you can see in the zoo, if you has ever been to zoo, just see this painting is changed. So, and this is also very dangerous. Many of the hospital, they sign the consent form for formula. The formula should only be prescribed as a medical intervention with a strict documented pediatric intervention indication. So this consent form should be abandoned. So, take home messages. It's very unfortunate that breastfeeding has been considered as one of the feeding choices. It is not a choice, it is a critical intervention which has a lot of influence through epigenetic mechanisms. This choice actively shapes the infant's immunological and metabolic future. It reduces the lifelong risk of non communicable diseases like type 2 diabetes, lymphoma, heart disease, and so on. Golden hour should never be missed. Practice skin to skin contact in OT, labor room, ward, and home. Encourage breastfeeding in sideline position. Do not swaddle the baby. In healthy newborn, no need to go for glucose level. Then breast milk jaundice should remain for a couple of weeks. Will remain for a couple of weeks. So exclusive breastfeeding should be encouraged. Routine suctioning should be avoided, and the need of our is to not to let our baby Abhimanyu fall into Chakravyu, top up traps, labeling low milk supply. There is a poem of 2 minutes only. I am just giving that away.
तुझे सब है पता मेरी माँ।
छोटी सी अभिलाषा है मेरे प्यारे डॉक्टरों से, जैसे ही निकालो मुझे गर्भ से, जोड़ दो मुझे मेरी माँ के स्तन से। शहद पीने की चाह नहीं, न ही मुझे नहलाया जाए, माँ का दूध पीने के बाद ही मुझे नानी, दादी और बुआ को दिखाया जाए। कोलेस्ट्रॉल कितना भी कम हो, एक चेरी के साइज के बराबर ही तो मेरा उदर है। कोलेस्ट्रॉल है मेरे लिए अमृत, मुझे न करो इससे वंचित। मैं निशक्त हूँ, पर तुझको तो पता है मेरी माँ, तू मांगना मुझे डॉक्टर से, न माने तो झगड़ लेना, गुस्सा करना, उनसे कहना विटामिन के बाद में लग जाएगा, पर मेरे सकिंग रिफ्लेक्स का यह सुनहरा घंटा चला जाएगा। जागरूकता के अभाव में, भ्रांतियों के दबाव में, गलत परंपराओं के निर्वाह में, सही ज्ञान की कमी के कारण मत वंचित करना मुझे मेरी माँ के अमृत पान से। कोलेस्ट्रॉल मेरी आंतों को साफ करेगा, उसकी रक्षा करेगा। स्तन के पास जाकर माँ के दिल की धड़कन सुनकर मैं बेफिक्र हो जाऊंगी। त्वचा की गर्माहट के साथ इम्यूनिटी भी ले पाऊंगी। मैं इतने अच्छे से सक करूंगी, ऑक्सीटोसिन निकाल कर माँ का रक्तस्राव भी कम कर दूंगी। साथ में सुलाना, कैंगारू जैसे चिपका कर रखना, अगर मांगो बाजार में भी तो शर्माना मत, पिला देना अमृत मुझे। परवाह न करना उनकी, उन्हें तुम देखना भी मत, जो तुम्हें दूध पिलाते हुए हिकारत से देखेंगे। देखना धीरे धीरे समय के साथ लोगों का नजरिया भी बदलेगा। जरूर आने वाले समय में सुविधाएं बढ़ेंगी, स्टेशन पर, एयरपोर्ट पर, ऑफिसों और मॉल्स में भी, कहीं भी तू मुझे बेफिक्र बेझिझक दूध पिला पाएगी। पिलाते रहना दूध मुझे 2 साल के बाद भी, मत लगाना चुकंदर करेला दूध छुड़ाने के लिए। कृष्ण और जीसस को भी देखो, पी रहे हैं अब तक भी। कभी हुई उल्टी, दस्त, चोट लगी या हुई तबीयत मेरी नासाज, तेरा ये ब्रह्मास्त्र काम आएगा, सभी बीमारियों को खदेड़ देगा मेरे शरीर के बाहर। छोटी सी अभिलाषा है मेरे प्यारे डॉक्टरों से।
तुझे सब है पता मेरी माँ।
Thank you, Dr. Neerja Pauranik, for such a practical and heartfelt sessions on breastfeeding promotion. Today's discussion reminds us that breastfeeding is not just a mother's personal choice. It's basically the public health responsibility. And we clinicians or we doctors should play a decisive role in promoting it, protecting it, and supporting it. And I'm so happy that the barriers, doctor, you have outlined throughout are the practical steps, how to counsel, how to encourage, how to support mothers, are the things that one of us applies from today, starting from not tomorrow in our own practices. So let's carry forward one counseling session, one delivery, one mother at a time. That's a very, very good things. And thank you for joining the Learn Simply Grand Rounds. And thank you so much. Thank you so much, Neerja.
Thank you.